Thank you very much. My name is Lucia Ferrara, and I'm a researcher at the Bocconi University in Italy, in Milan. And I'm very glad to be here with you. And I will present some of the first findings of a research project we are working on that is engaging the patient with HCV and NAFLD-NASH disease. And this is a case study of 10 healthcare organizations in Italy. First of all, I want to put some quick information regarding the backgrounds. Over the last decades, we all know that increased attention has been placed on measuring and improving the healthcare and the experience of patients. And patient experience is considered as one of the 3 pillars of quality in healthcare, alongside clinical effectiveness and patient safety. But if we look at the literature, we can see that there are several definitions of patient experience. In this context, when I mention patient experience, I refer to the patient experience is in a healthcare context is formed during the moments when the operations, that means the health service and the consumer, meet. But first of all, I want to talk about different definitions, because I will mention them during my presentation. We refer to patient experience, as I've already said, when we talk about the interaction that patients have with the healthcare system and the experience of patient that is created when they meet with doctors, what is the experience of patients relating to their healthcare plan and their and the relationships also with other facilities. But we also talk about the patient journey a lot, that is the series of encounters and consecutive events or steps, that means activities, interventions, staff interactions, as perceived by the patient. So it is the integrated care pathway, but from the perspective of the patient. We also talk a lot about patient engagement. In this case, we refer to the process of building the capacity of patients, of families and caregivers to self-care, so to take an active role in the management of their own care. But all this putting together, we want to talk more about what we call as patient involvement. That means to go a little bit further and to consider the active participation of patients in the healthcare decision-making process. So, regarding this, when we talk about chronic patients, we know that chronic patients are people who have multiple encounters with the healthcare system. They see a lot of healthcare professionals, they see a lot of healthcare settings, and they move around all these settings. And so their experience is central to gain the real patient experience of the patient. So when we're gaining a clear and a real patient experience of the patient in all their journey around the different healthcare settings, it is important to go from the symptom onset, so when there is the diagnosis of patient, till the end of life. So to consider what is the real patient experience of the journey, of the patient journey. So what is patient journey mapping? What we are trying to do with this project is to map the journey of patients in regard of the healthcare organizations. And this is beneficial both for providers and for patients. For providers, because it makes the care continuum continuous. Because we all know that breakdown in communication between providers due to geographical, technological, or network problems can cause gaps in the overall outcomes of patients. Mapping the patient journey is also beneficial because it means to close the loop. We always talked about the communication breakdowns, but also we need to talk about unmet expectation. Many times we don't know what are the expectations of patients, and we don't clearly clarify what are the expectations regarding also the complete healthcare process. And also, this means to continually improve this system, because it means to collect data, about the real patient journey, but it's not only important to collect data, it is also important to understand what the data means and to review the data periodically to improve to go from best to better and better in care for patients. But patient journey mapping is also important from the patient itself because it allows the patient to stop the care silos, because we always talk about fragmentation in care, and so it is important to let visible to the patient what are the blind spots, and to see that silos have a negative impact on patient experience. It means also to guide the patient expectation. Many times we learn that patients often don't know what is supposed to happen next. So the great fear for the unknown, the confused instruction always bring to lack of adherence. But it is also important to understand what are the pain points. That means to are the problems along the way, and these are also opportunities for the organization to improve the care process. And finally, it is important to emotionally connect with patients, to empathize with them, with their journey, to shine light on how they feel regarding the patient journey. And so, putting this as a background for our project, the main aim of our project is to gather information on the real patient journey of patients with two diseases that are HCV and NAFLD-NASH. I will explain in 1 second because we decided to focus on these two diseases. And also, at the same time, to identify what are the strategies to engage patients in the decision regarding their health. So to have a patient involvement strategies, to involve always the patient in the definition of the healthcare system. As I said, we decided to focus our attention on two disorders. On one side, the hepatitis C virus, that is a very known disorder that affects from 1 to 3% of the world population. It's an acute disease, but most of all is a chronic disease that can lead to major problems like liver disease and liver cancer. On the other side, we decided to focus to a not really known disorder, that is the non-alcoholic fatty liver disease. In this case, we are talking about a disease that is really unknown from the patient, and we estimate that from 30 to 40% of the USA population are affected by NAFLD or NASH. And the risk factors are the obesity. In this case, we estimate that from 30 to 90% of patients with obesity may also have NAFLD-NASH, but they are not aware of this problem. And also is a major complication for type 2 diabetes. If for hepatitis C virus, we have a therapy that completely changed the patient journey. We do not have a therapy at the moment for NAFLD-NASH, and the only things that we have in our hand is only the behavioral therapy. So we are studying what is the real patient journey of patients in 10 healthcare organizations in Italy that were selected in order to cover the national territory and also to cover several institutional settings. So we have local health authorities, but also hospital trusts and also university hospitals. Just to see what is the difference in the process in the real patient journey, depending on the institutional setting. We're using a mixed methodology, and we're employing a customer experience mapping in order to understand the journey of these patients. When I talk about mixed methods, I mean that we are using working groups with professionals, but also workshops. We are analyzing the local documents. We are doing focus groups and interviews both with professionals on the one side and with patients on the other side. And we are going to distribute a survey to patients and caregivers to understand what is also their feeling regarding their patient journey. So what about the working groups? We decided to create two kinds of working groups that put together several professionals. I mean all the professionals involved in the integrated care pathways. So we have clinicians, but also we have GPs, we have also the patients, just to understand what is the different point of views from the different shareholders and stakeholders involved in the process. This is a broader project that will last for 2 years, and we are just at the beginning of the process. And what I'm going to share with you is the organizational analysis and the integrated care pathways that we are mapping with the professionals and with the patients. This is a project that will last till almost the end of 2020, and this is part of an observatory on chronic disease and primary care that Cergas da Bocconi were running in Italy. So what are we doing in our process mapping? We are mapping the patient journey that is a visual representation, and we are using the flow chart to understand what are the processes, what are the interaction with the organization, what are the activities, the entrance and the exit points. And we divide the process of care in 3 major episodes of care that we call diagnosis, treatment, and follow-up. For every single episode of care, we try to understand the 5 W. That means who are the professionals involved, what are the activities and the decision, the organizational routine, when, in which moment of the journey people are involved, where, that means in which setting, why, that is what is the main aim to reach for each procedure that we do. I will show some examples that are our results in this moment. I will focus on 2 models of care that we are discovering. If we look at this slide, we have a first kind of model of care where there is a consultancy role from gerontologists. So if we look at the screen, we can see that there are several the patient has several comorbidity, and we have several professionals involved that they are taking charge of the patient. But the process is really fragmented, is in silos. And then we have the gastroenterologist, that is a specialist, that acts mainly as a consultancy role. But in this model of care, we don't see any correlation, any coordination between the professionals involved. I will show you another model that we are discovering with the focus group with professional and patient. That is what we call the referral model to specialist professionals. In this case, we have the involvement of GPs, outpatient setting for first contacts and also for diagnostics tests. And so many professionals are involved at the local level. But then we have a specific referral with specific protocol between first level and secondary level specialistic center. And in this case, there is a clear owner of the process, a care manager that is the gastroenterologist, who take charge of the patient and follow the patient during the journey. What are the results of this analysis? First of all, we can say that in every context that we are analyzing, there is not an integrated care pathway available at the local level. There are some form of collaboration and cooperation among several actors, but not a formal integrated care pathway. This is a simple method that can be used to map the patient journey, both from patient and professional perspective. It is useful to identify the professionals involved, the results involved, but also the gap in the integrated care pathway. We call this a smart model that is simple, that is measurable, achievable, result-bounded, and time-bounded. That means that it's a model that is simple and replicable by any organization and hospital trust who wants to know more about the organization and the patient journey of the patients involved in their process of care. But there are other questions. What is the role of different professionals involved in the process? We can see that more fragmentation is linked to poorer communication and coordination among providers. And so as I presented you 1 second ago, I was talking about 2 different models. And we can see that there is a clear correlation between the models of care, how professionals interact, and how patients are feeling about their own care. There are several breakdowns in communication from primary level to specialistic level, and this causes absence of reference contact, and this causes absence of continuity of care and lack of care plan adherence. But the major questions, and that is important also in this session, is where is the patient? Because we cannot find explicit strategies of patient engagement and patient involvement in all the hospitals and all the local health authority that we are mapping. But we know that the engagement of patients has a central role in the change process within healthcare organization, especially in defining the integrated care pathways. So what are the next steps, and what I want to point out as a discussion also for you? Another point before going to the discussion, because we know that there is an innovation for ACV patients. We know that 80% of patients are known, and among those who are known, 90% have been already treated. But there is the 20% of patients who is completely unknown. What can we do with this kind of patient? How can we involve them just to follow up the process? And on the other side, we have the NAFLD-NASH patient. I'm using the image of an obesity person because they are happy, they feel okay, but they don't know to have a problem with their liver that is suffering. So what are the discussion points to conclude? Healthcare organization, we are considering how to consider and taking into account the patient perception, patient preferences, and expectation. On the other side, the experience of patient could be a driver to implement operational and strategic model to redesign also the integrated care pathways. And finally, there is a growing need also to develop some strategies to involve the patient in the decision-making process. Thank you very much. Yep.
Thank you, Lucia. Wonderful, excellent. Lucia really spoke about her findings, here, come join me over here, of not yet seeing it in local communities and integration where patients' voice is engaged as part of the process. Let me start with the first question. That was my timer, I apologize. What is your best advice to all of us around how to move forward?
Mm-hmm. My suggestion is it's also what we are trying to do with the focus group is to involve the association of patients as the voice of patients. But what we discovered is mainly for this kind of patient, for example, I will use the example of HCV patient. Those who are unknown in this moment are people who have, we can consider them drug users or sex workers. So it's also difficult to involve them. But we can use the association, we can use these GPs, we can use the territorial level just to involve them also in redesigning the process of care and see what's wrong, what's the process, what are the pain points, what can we do best to integrate them and to consider their point of view in the comprehensive strategy with them, I would say.
Thank you, Lucia. An opportunity to hear from groups that have already engaged patients and their families to help inform. What about for anyone in the audience? Do you have any questions for Lucia? Thoughts, reactions? Anything you'd like to add to what she said? Okay, wonderful. Well, a warm and big thank you on behalf of everyone in the room and everyone who's joining us virtually. Thank you.